also welcome to this wonderful space. And great to see such a good turnout for this starting. In fact, there was a traffic jam at the entrance as I drove in. I thought, wow, he's really attracting quite a crowd. But really, it's wonderful to be doing this because it brings the community together, and of course that's exactly what IDORI is intending to do. As you know, bringing the infectious diseases experts together with our cancer experts to really cross-fertilize and to learn from each other. And there's a lot of excitement actually. In fact, people have always thought of, as you know, cancer and infectious diseases so separately, but there's so much overlap, so much opportunity, so much potential. And I think that's really reflected here as well, seeing the diverse audience, including Professor Bloomberg, all the way from NICD. Welcome. So really, it gives me great pleasure to introduce you to the first speaker, who I think you all know very well, because he is currently the interim director of IDORI, but perhaps you don't know about all his amazing accomplishments. And he told me to keep it short, but actually, no, this is it's a time to brag about you, Rob. So before he joined Wits, Rob was the director of the Emory University Global Health Institute, and he was the overall PI for something called CHAMPS, which I'm sure many of you have heard of, which is a network, and it stands for Child Health and Mortality Prevention Surveillance Network. So it provides an array of new insights into the causes of neonatal, infant, and child deaths in sub-Saharan Africa and South Asia. He's also the co-PI for an NIH-funded Center for Research on Emerging Infectious Diseases in East and Central Africa, CREED-ECA, and he's the PI for the Bill and Melinda Gates-funded Scientific Advisory Process for Optimal Research on Typhoid Fever Disease Burden, SAPORT. But Rob trained in internal medicine and infectious diseases at UCLA, and I won't go into the dates. As an infectious diseases fellow, he worked on molecular immunology with a focus on Legionella. He was at the US CDC for 26 years, impressive, until 2013, where he focused on pneumonia, diarrheal disease, immunizations, emerging infections, and urbanization. His time at CDC included 13 years outside of the US, including 4 years based in Dhaka, Bangladesh, where he was the founding head of the program on infectious diseases and vaccine sciences, and from 2000 to 2004, and then 9 years in Kenya with the Kenya Medical Research Institute, stroke CDC, including serving as the country director from 2010 to 2013, and the founding director of the International Emerging Infections Program Global Disease Detection Division in Kenya. And the reason why I wanted to say all this is because you can see not only has he got enormous experience in leading premier institutions, but he's heavily committed to solving problems outside of the US, in particular in Africa. And we really, welcome. We're really happy that you're here to help us grow IDORI. So Rob is also part of the. He was elected to the National Academy of Medicine in the US in 2017 and the American Epidemiological Society. So Rob also asked me to review his NRF application. So I have to say I was just stunned by the number of really pivotal and groundbreaking studies that you led on some pretty important epidemiological findings, and many published in NEJM and really. So I won't embarrass you anymore, Rob, but really an exceptional CV.
Now I'm really on. So thank you all for coming. It's great to see you here. So many faces that I've come to know quite well over the last year and a quarter or so. So a couple of weeks ago, I was in an Uber, and I was just sitting there like I usually do, and the Uber driver asked me what I do, and I said I'm a medical doctor, and then he grew silent for a while, and then he said, I've had a very bad last few weeks, and I said, how? And he said that a week before, his 71-year-old father had gone to the hospital with a little bit of difficulty breathing. And that yesterday, the day before my ride with him, he got a call that his father had died, and he was told that he had prostate cancer. He died of prostate cancer. And he said, how could that be? Because neither he nor his father knew anything about prostate cancer. And then he said, as if that wasn't enough, that he had his best friend, a 41-year-old, was a month before had presented to a clinician just with some abdominal discomfort, some indigestion, basically. And 2 weeks later, his 41-year-old best friend was dead with colon cancer. And so for me, hearing this story, I mean, I was stunned and didn't really know what to say other than just words of support. But to me, it highlights what we're trying to do with IDORI. And so the title of my talk is, as Lynn said, I'm an infectious diseases epidemiologist. What am I doing here? Focusing on cancer research. And it's, one thing, it's a great thrill to be here in this wonderful environment with world-class scientists and future leaders in science. So I'm going to sort of describe sort of my viewpoint about IDORI and indeed how I got here. So in order to explain that, I need to tell you a little bit about my history. So when I was like in high school, my idol was this guy, Clarence Darrow, who you may not know here. I'm not sure. Anybody here of Clarence Darrow? So Clarence Darrow he was a lawyer, and he focused on the most marginalized, vulnerable populations, and he used the law to kind of balance things, to address things, to address the issues social injustice issues that were facing these people. And I said, that's what I want to do. And so I went on a course to become a lawyer. And it all was going quite well. And then this happened. And you may not be familiar with this part of American history, but the guy in the middle was a lawyer who was an American president named Richard Nixon. And he's surrounded in this photo by 4 lawyers. And in fact, the whole crew that were involved in this very upsetting, compared to what we're dealing with these days, is nowhere near. I mean, it wasn't as upsetting as things might have been. Little did we know back then, but it was very upsetting, especially to a young college student. And I began to question whether a career in law would take me where I wanted to go. So I really made a sudden pivot and examined whether going into med school could make provide a different opportunity to do the kind of thing I wanted to do and basically to help people. And so I did. I ended up going to medical school, and this is me graduating. That's my mom on my right with very big hair at the time, which was the style, and my dad on the left, who oftentimes thought he was a security guard, I think. He had this expression, but he was very happy, even though he doesn't show it. So when I graduated medical school, I decided to go into internal medicine, which in the US, that means focusing on adult medicine. And during the next 4 years, I spent trying to figure out what subspecialty I wanted to go into. And at that time, and thank you for not mentioning the years, Lynn, but at that time, there was only one subspecialty that you could use your clinical acumen and the tools available to actually cure an adult patient of their disease and basically return them to whatever the condition they had before they got their illness. All the other subspecialties, which I loved, including oncology and cardiology, were basically palliative in those days. There were very few, cures. That has changed in the US, especially for oncology, but not so much yet in Africa, and that's part of what I want to talk about. So I went into ID, and that's me. I got assigned to a molecular immunology lab. My mentor there was a world-class molecular immunologist in those days. It was very different than molecular immunology is now. accomplishment was a few lymphocyte proliferation assays. Nowhere near the technical capabilities that exist now. And I loved what I did, but I also had a feeling that for me, a career in the lab wasn't going to be what I needed to do. So I explored CDC, and I ended up doing the EIS program at CDC. And there was 2 years of very intense, like learning about epidemiology, responding to outbreaks, and so on. And then I ended up staying there for 26 years. The first half of that was focused on a continuation of what I had studied in the lab at UCLA, which was bacterial respiratory pathogens, and it extended especially to pneumococcal disease. Did a lot of work on prevention of pneumococcal disease. It was right around the time that PCV, pneumococcal conjugate vaccine, was starting to come out. In fact, my very first trip to South Africa was to help Keith Klugman in about 1995, I think, or 96, put together the plans for the PCV trial, and I ended up being an advisor for that process. That, by the way, is where I met the current dean here, Faculty of Health Sciences, Shabir Mahdi, who was a very young, I think he wasn't small, but he was a very young fellow at the time. But then after those, the first 13 years, and I was the director of the U.S. National Vaccine Program Office, because a lot of the work that I did ended up being about immunizations. I got very deeply involved in that. But then I decided I wanted to get back into the field. And, and my first overseas assignment was to start a new program at really the illustrious, many of you probably are familiar with it, Research Institute in South Asia called ICDDRB, to build a program on infectious diseases and vaccine sciences there. We spent 4 years there, really a world-class place, incredible scientists, and major problems. So in Dhaka, in Bangladesh at that time, it was the most densely populated country in the world, and it was one of the 5 poorest countries in the world. That combination meant to me as an epidemiologist that I needed to broaden my horizons. My focus on my narrow area of respiratory diseases wasn't enough. The types of things that people were getting exposed to and having severe outcomes from were many. There were many marginalized populations. Inequities were huge. And so I got very involved in things like typhoid fever, still on some vaccine studies for respiratory diseases, as well as for cholera and rotavirus. And then there were outbreaks that occurred. And I don't know if you know of Nipah virus encephalitis, certainly Lucille does. That became a big problem in Bangladesh right around the time that I arrived there. 2001 was the first outbreak, and we did a number of seminal studies on Nipah virus. And then after 4 years, I was asked to go and lead a new effort in Kenya to build this emerging infections program. And there, it was built around surveillance. And so we built surveillance sites in a couple of key locations, one in rural Western Kenya, and then the one that was sort of closest to my heart was in an urban informal settlement in Nairobi called Kibera, which is used to call itself the largest, but it's probably not the largest, but still a major informal settlement in Nairobi. And there also, many of those diseases that we were focused on in Bangladesh were also present among these people living in Kibera, where it was a completely informal environment, where there's no, infrastructure for water, for sewage, for housing, for security, for fire. It was a very challenging environment. And the reason I'm telling you all of this is that somewhere along the lines here, I had forgotten about Clarence Darrow years before, decades before. And then I think there was a point where I was sitting in Kenya where I realized that it had all come full circle. I had wanted to focus on the most vulnerable, the most marginalized populations, and to find pathways that at least would begin to address some of the big challenges. And instead of doing it with a legal lens, I ended up finding myself doing this with a health lens, with a medical lens, public health. And in a lot of ways, that was maybe more impactful than what I had originally imagined, because there are so many things that we can do to address those inequities. So after 9 years in Kenya, we went back, as Lynn said, to Emory. I was the head of the Global Health Institute, and then got involved with, to me at the time, was the paramount example of inequities, which was childhood mortality. We were fortunate enough to get a very sizable grant, the largest that had ever been given at the time. I think it still might be, to do CHAMPS. And which the difference, for those of you wondering about CHAMPS, you know, up until there was this formal work, this formal project, the understanding about what was killing kids essentially came from verbal autopsies. These post-mortem questionnaires, mostly of mothers, of parents, and you can imagine how nonspecific and how simply, in many cases, wrong those data were. Also, there was information from IHME, the Global Burden of Disease folks, and they would focus on just one cause of death that they would get from verbal autopsy, sometimes from medical records. And that also was misleading and inaccurate. And so what CHAMPS did was it added post-mortem, minimally invasive tissue samples to all the other kinds of data, sophisticated testing of those samples, and far more precision about the cause of death. And I don't see the CHAMPS leads here in South Africa here today, although I just may not be seeing you. But clearly there needs to be some seminars here about CHAMPS, because CHAMPS is making all sorts of discoveries that are directly related to interventions to reduce childhood mortality. And the issue, the inequity issue here, is that the sites here that are part of CHAMPS represent an example of what you can't believe still exists in the third decade of the 21st century. So in Sierra Leone, for instance, in Mali, the childhood mortality rates are higher than 100 per 1,000 live births. That means that by the age of 5, there's a 1 in 10 or higher chance that a child will die. That's much better than it was when I first got into global health, of course, but it's still unacceptable. And Soweto is one of the sites. And when I stepped down from CHAMPS, so in the end, the Gates Foundation decided that they wanted CHAMPS to go on, believe it or not, for 25 years. And so after, in 2020, where we were at a very high point, the project was going well, all the sites were functioning, we were getting the basic work out, the papers, fundamental stuff. I thought that's a good time to pass that on to some younger, hopefully energetic, hopefully PI, and then sort of move on to something else. So that's what I did. And shortly after that, I got a call from the dean here. Now, I had been having discussions with the dean for years. You know, I was the head of a global health institute at Emory University in the United States. And I thought that you don't need a global health institute in the United States, you need one in Africa. And so I've been talking with him for years about why not build a global health institute at Wits? And if you do that, I would be happy to come out and advise on that. That didn't take immediate traction. But what did take traction was Shabir had an idea of building something that he called IDORI, the Infectious Disease and Oncology Research Institute. And his initial idea, and the way that this has evolved, was, first of all, around infectious diseases, there is truly, as you I'm sure all know, or you're part of probably many of you, there is world-class work coming out of Wits. The work is also, as it is in many places, focused in individual groups, physically quite separate because of the geographic distribution of Wits in Johannesburg, and also the natural tendency for a team to focus on its own work. I'm trying to avoid using the word silo. I just don't like that word. But but there are these silos, and the idea was to integrate that infectious disease work at Wits. And then also there's first-in-class oncology work, certainly in Africa, here at Wits. And also that needed to be integrated. So there was a vision of an integrated infectious disease group at Wits and also in oncology sciences. But what really was interesting was the idea of putting them together and the sparks that would fly as a result of that. Because nowhere in the world is there a formal, systematic institute that puts infectious disease scientists together with oncology scientists and getting them to think together and with the sort of intent, the mission-driven intent to do something really innovative that would affect disease burden. And so when you first asked me about this, I actually laughed. You can confirm this. I think the laugh went on for about 15 seconds or so. It may have been a little bit longer. Because I didn't think that, so for me, thinking about oncology was just way out of my comfort zone. And however, he gave me a little time. I thought about it, and the idea was just to come out here and be an interim director to move this forward. And when I got to thinking about this, I began to feel that the problems that are being addressed now with the recognition of how important cancer is in Africa is a cut of the same kind of thing. It's a different discipline, but it's a cut of the same kind of thing that's been driving me throughout my career. And so ultimately, I decided to explore this further. And so let me just go into a little bit about what made me realize that this is a critically important thing to do. And one thing is looking at pediatric cancer, 5-year survival from the US National Childhood Cancer Registry data. So this is a bar chart that shows a 5-year survival on the y-axis, and then the bars are broken down by ethnicity. So on the far right, you might not be able to see this, but on the far right are white children. Next to them, the most acute difference is basically black children. And you can see, and these error bars up here show that there's a statistically significant difference between blacks and whites children for 5-year survival. It's a real difference. Amazingly, that's the incredible thing, is that the 5-year survival for childhood cancer in the US is 90% in whites. In blacks, it's lower. And it's importantly lower. It's like 81% or so. And that is something that has to be addressed. But by contrast, the 5-year survival in Africa for pediatric cancer, most people say it's about 20% in most environments around cancer, but that's the range. That's unacceptable. Again, the same sort of thing as I was talking about before, massive difference. When looking at adult cancers, this is a heat map that looks at mortality to incidence ratio. That's what the MIR stands for. And this is a very crude thing. So it just counts the number of incident cases in a year, and it counts the number of deaths. So it's kind of a crude substitute for case fatality rate, but it kind of gives you an idea. So liver cancer is one of those things that you don't want to get. Nobody does well with liver cancer, no matter where they are in the world. But on this heat map, you can see that globally, the mortality to incidence ratio is 0.67, about 2/3, in kind of a yellow beige color. But all of Africa is way over on the right. And that's simply an example of cancer being detected way too late. People present right at the end of their course. Sometimes the liver cancer is diagnosed at death. And there are other examples as well with prostate cancer, where it should be globally is here in the blue, 0.25. And that is about where South Africa is actually. But you can see that for most of the rest of Africa, it's much more in the middle here. So a huge difference And then this is a slightly different slide. It's probably not legible actually, but for colorectal cancer, that's colon up above and rectal below, Africa is kind of at the bottom there in terms of incidence. So compared with Europe and the United States and elsewhere, the numbers that are reported are less. However, there are issues there in terms of, as you can imagine, of diagnosis and reporting. There also might be a real difference in terms of incidence of colorectal cancer. But importantly, the mortality to incidence ratio, when there is a diagnosis, is again much higher in Africa when compared with the United States and globally. And very importantly, as I'm sure you know, that there's kind of an epidemic here, but it's also globally, but pretty big here on the proportion of early onset colorectal cancer. So the proportion of people diagnosed with colorectal cancer who are under 50 is based on wonderful data that June Fabian and Brendan at Bevington provided and their team. And it's using it's nice collection of data from Wits hospitals. It's around 26%. It's pretty high. I mean, a quarter of the colorectal cancers are under 50. That's influenced by the fact that compared with the US, for instance, there's not as many older people. So the ratio is higher than you'd find in the United States as an example, but it's still, some of that is that artifact, but it's still unacceptably high. I was just in Boston last week or 2 weeks ago meeting with a group that has a huge amount of funding from the National Cancer Institute and the Wellcome Trust to understand the levers for early onset colorectal cancer. And they were not aware of the kinds of teams and skills and data that are available here. And they are very interested in including us in their network, and we'll have some follow-up discussions and calls with that group at Harvard as a sort of a starting point for us to look at this in a very big way. So why is all this? Why is all this happening? I mean, I'm sure you're all thinking, you're hypothesizing what's going on, and the most obvious thing is access to care, right? And timely access to care and for diagnostics. When it comes to cancer care itself, the green here relates to the number of cases per oncologist. And it's greater than 3,000 cases per oncologist or no oncologist in some cases. And you can see almost all of the green that is to be shown on this map is in sub-Saharan Africa. So there's that problem of having special clinical capabilities for cancer. And on this slide, it simply looks at across the board on specialist physicians, nurses, and importantly, what I'll point out is radiotherapy units. Sub-Saharan Africa, in terms of density of specialist physicians and nurses, is behind the other parts of the world. And when it comes to something like radiotherapy, it's almost non-existent. We're talking about availability of 1 per 10 million population compared with what's seen elsewhere. So there's real infrastructure issues, and the playing field is simply not level for cancer burden. So what do we do about it? So what IDORI is focusing on and working with various collaborators on is how do you strengthen the workforce? It may not be producing oncologists, that may not be practical in the short term, but there may be training that can occur of first level physicians, even community health workers, in some cases to recognize early signs of cancer. Maybe it should be part of IMCI even, integrated management of childhood illness, in the case of pediatric care. Cancers have to be detected early so that there can be effective treatment. So there needs to be access to healthcare, and there needs to be access to early diagnostics. But you can't do early diagnostics unless you can provide therapy, right? What's the point if you're going to diagnose and then not have the ability to treat? So there has to be access to effective therapeutics. And right now, for what has changed the balance in high-income countries is state-of-the-art chemotherapeutics that are actually becoming highly effective, incredibly expensive, and completely not available in Africa. So what is needed, at least as far as we can see, is to build R&D capacities in Africa, and ultimately, and this is where IDORI comes in, both of these, where IDORI comes in, I think, to identify novel, effective, feasible approaches for prevention, diagnosis, and treatment. So again, going back to when I was in med school, you know, so if I had raised my hand back in my first year or second year of med school, and I had said that, hey, I think that cervical cancer, which was killing lots of women everywhere in the world, including the United States, could be prevented by preventing a virus that probably no one in the room at that time would have heard of, I would have been back to law school. I think it would have moved me very rapidly, because it was just a crazy idea. And yet, sorry, now I'm really in trouble. So yet you have the DG, the Director General of WHO, who's very seriously pushing for elimination of cervical cancer as a public health problem. And the way that's being done is the knowledge of the role of HPV. And so I think Harold Zerhausen would have appreciated the George Bernard Shaw quote down below, that all great truths begin as blasphemies, because as he did his early work, he was convinced that there was some sort of mitigator, some facilitator for cervical cancer. And his early work with immunohistochemistry in early onset cervical cancer, and even looking at squamous cell and adenocarcinoma, found evidence for HPV. And he wasn't seeing that in the healthy cervix. And he went through a barrage of resistance and a lack of funding. The funders just were not interested. And when the Nobel Prize Committee awarded him, I think in 2008, it didn't so much focus on the science. It focused on the perseverance. And it was that was critical. Can you imagine if he had just caved and said, I guess no one's buying this, let me move on to something else. And it's that kind of transformational change that we think there's more in store. We already know, Patrick can do his own seminar, and hopefully will, on the relationship of what we can do about the knowledge of hepatitis B and hepatocellular carcinoma, what we aren't doing enough of now, and the relationship we know of Helicobacter and gastric cancer, schistosomiasis, and bladder cancer, and of course EBV and Burkitt's lymphoma, and there are a few others. But there's reasonable evidence to think that there are more, and exploring those and finding those connections could make a big difference. So the initial areas of focus, there's plenty that we're not doing yet enough of, with the knowledge that we currently have, even for cervical cancer alone, to optimize the prevention and early diagnosis of cervical cancer. So there's a lot of implementation science. We're busy trying to nurture a sort of a network of researchers doing this kind of investigation around Africa. So we've built MOUs, for instance, with Uganda Cancer Institute, Rwanda Biomedical Center, and we're building more of those. And it looks like we may have some help from some outside groups who are also interested in doing that. And the same with training on cancer management. As I mentioned, there's a variety of avenues to go on that. A couple of weeks ago also, I was at St. Jude, the big pediatric cancer research sort of mega operation in the United States, in Memphis, Tennessee, and they're very interested in both the second and third bullet there, and are already working with Geeta Naidu and others to do some of this, but there's a lot more that they're interested in doing. And then the excitement is around this microbial viral microbial and viral cancer intersection, discovering new pathways for viral and microbial oncogenesis, and looking at example microbiomes in cancer. When I was in Boston, I met with a couple of groups actually, that have been exploring the relationship of an oral bacterium, Fusobacterium nucleatum, associated with gingivitis, and it's just something that dentists are very aware of. But there's evidence now, and there was an article published in Nature last month that suggests that Fusobacterium has a role in facilitating colorectal cancer. Maybe that's going to be important here. We need to know. And then it'll be important to have early stage diagnostic and screening tools. The DIH Diagnostic Innovation Hub is represented here today, and I think they're going to play a really key role in advancing that. And then there will be vaccines and therapeutics already in development in several of the labs. And I think what we have to get to, though, is we're great at the science. We're great at publishing in very high impact journals. And we need more experience and expertise in pushing that information into product development, into commercialization, and ultimately into impact. And that is an area that IDORI is sort of heavily focused on, and I think there's a huge need for this. So we have some seed funding that we were able to provide to get some proof of principle work out, get enough data that could then go into a proposal for additional funding. And we put out a call at the end of the year last year. We got a lot of responses. We were only able to fund 7 very excellent proposals, and I'm just going to show 3 of those because they're kind of relevant to what I've been just talking about. One is assessing the oral microbiome as a biomarker for esophageal squamous cell cancer. That is led by Carl Chen and with a larger team. And I think that's going to provide very important sort of firmament, substrate, foundational data that hopefully will lead to the ability to successfully seek larger funding to investigate that. I mentioned prostate cancer as a real important issue. There is evidence, not from Africa, but from other locations, that prostate cancer tissue, when compared with healthy prostate tissue, is more likely to have the presence of HPV. Maybe HPV is playing an important role, and Pascal Willem is leading that effort to identify HPV in prostate cancer tissue and to serotype it, working with a variety of collaborators, including at CDC. And then this issue of early onset colorectal cancer, especially in Black South African patients, we're seed funding a project that's led by Clem Penny and Musa Marimani and Michelle McCabe and others to look at what's going on. Is there viral co-infection? Perhaps that will also lead to understanding some of these microbiome questions, and looking at cancerous tissue versus non-cancerous or healthy-ish bowel tissue. So, as you can get a sense for, IDORI is driven to reduce those inequities. It's all about the inequities that sort of drives things to solve really the growing problem of, I haven't really shown that, but cancer epidemiology shows that that problem is growing substantially as the population ages, and will become, over the next decade at least, a massive problem in Africa. Assist in the advancement of health in general, and really drive, lead, and witness scientific growth and leadership. So a big part of what we want to do is provide a pathway to build the next generation of researchers in Africa. And what I always say when I'm traveling, and I mean it though, I'm not just saying it to soothe or to get interest, is that what's learned here in our work is going to be relevant for the world. And we just are in a position to evaluate a number of these critical questions optimally. So it comes down to villains and heroes, right? I mean, and so there are so many villains out there now. I mean, I could cite climate change, and I will cite it actually, and microbial resistance, the growing burden of cancer, the risk of another pandemic. But you can take comfort in, and I think it's real that we have this scientific base that is very solid with growing tools and expertise right here. And we have collaborators that exist currently, and we're building further, that should make progress against these villains. And we have, speaking of heroes, we have our external scientific advisory committee, which is being formulated and will be meeting soon, includes a variety of people, just like IDORI, coming from different disciplines, including the regional director of WHO, Sidi Moati, who's really has been very excited about what IDORI is setting out to do. The head of NCDs for the Africa CDC, a leader in cancer epidemiology and burden of disease from IARC, the International Agency for Research on Cancer, and a number, I'm sure you know, a number of these other great scientists. And then we also have an internal advisory committee that we call the IDORI Directors Core Team for Science and Strategy. This is our current slate of people that includes several of you who are in the room who advise IDORI, advise the director on critical areas of focus and on priorities. And we also have what we call the IDORI Edge Team. And the IDORI Edge Team will be advising us as we go forward more on being edgy, on keeping us on the cutting edge of work, but also, as I often told the Edge Team, I have one of my kids lives in Austin, Texas, and the slogan, if you've ever been to Austin, Texas, is "Keep Austin Weird," and they're proud of that. There's signs all over the airport and everything. And our slogan is "Keep IDORI Edgy," and these are some of the early career scientists who will help us think about how to engage young and up and coming, both trainees as well as people who are making decisions about long-term career, and also helping us with our seminars so that they're exciting, hopefully more exciting than what you're witnessing today, and just thinking about the research as well that might be particularly edgy and to find novel approaches, and so it's an important part of us. And so this vision that Lynn mentioned at the outset, that we're bringing people together to collaborate in ways that has never really happened before, not just at Wits, but really anywhere, bringing these people from different disciplines. And part of what's going to help, the VC has really gotten behind the concept of IDORI, but also behind this idea of collaboration, and has led to basically the purchase of this new campus, where IDORI will be the first occupants in 4 of the 11 buildings on this campus. And we're in the process now of working with the first phase of scientists who will be moving there. But ultimately the vision, and it's a beautiful campus. Some of the inside of the buildings need renovation, and that's what we're working on, especially to accommodate the laboratories. But what this will do, there's outdoor spaces that are kind of incredible. There's actually a braai area. I mean, I'm vegetarian, so I'm not sure how I'm going to use that, but it's a great place to kind of create this social interaction. We want this dynamic, bubbling, environment for collaboration. And also, for those of you wondering about this, there's plenty of parking, and it's like huge parking areas. And we are also planning on building a coffee shop there, because that's a place where people will bump into each other and learn what each other are doing. And so it's very exciting. Over the next 6 months, a lot's going to be happening over there. This is at the old Isle of Houghton, which is opposite Rodin School. I'm pronouncing that correctly. So, in a word, in a nutshell, IDORI exists to leverage the convergence of scientific inquiry and infectious diseases, all these things that are listed, into a highly collaborative and integrated ecosystem, and to conduct research analysis and develop products and tools that will do this, will advance prevention, early diagnosis, and management of high-burden cancers and infectious diseases. And importantly, provide a nurturing and supportive environment for developing, promoting, and supporting successful academic careers. One step towards that is we recently were awarded a grant from the African Population Health Research Center via their project called CARTA, which Sharon Thon is actually a co-PI of. We have now a CARTA research hub that involves Wits in South Africa, Rwanda, and Uganda. And one quick thing just to say that, you know, I'm very excited about this intersect of infectious disease and cancer. That's really where the magic is, I think, because no one in the world is systematically doing that. It's really first globally, and I think there's really important things to be done there. But that's not the only thing that we're going to be doing. There are existential issues that we're all facing. You know, there's a lot of chaos in the world right now. I don't know if you've noticed, but there's science that can address some of the things that really cause an undercurrent of worry and concern. One is the likelihood of disease X, the next emerging pathogen. I think for a lot of reasons, it won't be 100 years to the next pandemic. I think that there's a lot of factors coming together that increase the likelihood that this will happen soon, and I think that sooner, and scientists here are in a position to help in detection and in response, research response, and also in preparedness. And you can't ignore antimicrobial resistance. When I was talking about CHAMPS, one of the findings at CHAMPS is that more than 30% of deaths in under 5 children have Klebsiella pneumoniae, a gram-negative rod, in the causal chain. That was absolutely not known before. But one of the things that is particularly concerning about that is that most of the Klebsiella pneumonias are highly drug resistant. The ones certainly that come from here are like XDR. It's an exceedingly big problem. So Jeremy Nell and a whole team of folks are working with IDORI to begin to collect and curate data that will help Wits understand what's going on and then lead to a stronger research program around AMR. And then I can't, leave the floor without mentioning climate change. The reason is this whole talk is about inequities. And who does climate change affect the most? It's the marginalized, it's the people in lowest income countries. The cartoon on the left is a metaphor, really, but when we're talking about rising sea levels, the countries that will be underwater, metaphorically, are those low, and some of it's not metaphorical. For instance, in Bangladesh, but will be low-income countries. And so there's an environmental justice issue here. And and that leads to sort of a view of not just climate change, but this concept of planetary health. And we have scientists here and a whole sort of machine to begin to look at climate change, One Health, and the concept of planetary health. And so just to highlight some of the leaders in this, Imran Velodia, who's the Pro-Vice Chancellor for Climate and Inequities, has become quite involved in this topic. Matthew Chersich, who is now physically present up in Trinity College in Dublin, is working now half-time, 50% at Wits, and will be involved with planetary health, developing a planetary health program. Mariki Venter, has just joined us from UP and is going to be leading One Health efforts. Gloria Maimela is from Wits RHI, is focused and very productive in the area of the impact of heat on health outcomes. And Francois Engelbrecht at the Global Change Institute is a climate change modeler. There will be many others involved in this, but these are the key people. So, just to say that this is the end of my talk, but it's really just the beginning of what we're doing together, many of you who are in the room. It's also the beginning of a set of seminars, and that will happen monthly, and I think will be very, very exciting. And just to say that, you know, when times get tough, you have to rely on other people's experience. So, you know, it was Mandela who says that it always seems impossible until it gets done. And it was the great football player Pele who said, success is no accident. It's hard work, perseverance, learning, studying, sacrifice, and most of all, love of what you're doing and are learning to do. And Pele should have been a charter member of IDORI. So thank you very much.
Thanks so much, Rob. It's really quite remarkable what you've achieved in 14 months, generating a lot of buzz and excitement around IDORI and some of the successes you've had in terms of attracting funding. And I was really pleased to see that you got a lot of applications for your seed funding, because that tells me a lot of people want to be involved in this space. So wonderful. So we now have some 15 minutes for some Q&A. And I think there's a roving mic, so please don't be shy. Now's your time to ask questions. But please don't ask questions, when are we moving into Isle of Houghton? Because that's a moving target, I think.
Yeah.
I mean, we've heard a lot of bits of this, but it's wonderful to see it together as this cohesive vision. And I wonder if I can press you a little more on your thinking, because I think it's important when we think of impact, right? And a lot of the work you presented and a lot of the work we're thinking about is really around new products, new policies. How do you change the way healthcare is delivered? And I think critical to this is our engagement with policy makers and regulators. And it's like the end, you kind of mentioned some people who'd be joining the IDORI board, but can you expand on that a little? Like if we come up with a new diagnostic, it would be really nice to have the regulators be part of the journey so that when we go for the approvals, you know, we get them, and you can actually create meaning out of the work that's done in IDORI. Have you given this some thought?
So we haven't moved very much in terms of working with regulatory folks, but I do think they need to be engaged. I don't know what I should say or can't say. I'm sure I can say this, that you know, Glenda Gray will be joining Wits after she finishes her work with MRC, which is at the end of June. And I just had a call with her yesterday and kind of went through a lot of what I'm thinking about with her, because she's going to come on and help to advise the, you know, the director and the whole IDORI process. And this is the things you focused on. Is we need to be thinking about that, and so I'm hopeful that she'll help, and we need to, maybe you can help too. We need to have a kind of a team to think through that in terms of the vision for policymaking, and it's part of the reason we have C.D. Moeti and the Africa CDC on the board is to think through how we engage early on advisory processes, recommending bodies, advisory processes, government bodies. Because what my own experience with this is if you do great work and then you come to those bodies later on, you say, look what I found, this is really great. A lot of times you get shoulder shrugs. Like, that's great, but that's not really what we were thinking about. And so I think those conversations need to happen early.
They're really inspiring, and I think you've done great work. So taking a lesson from infectious diseases to oncology, and I think HPV is a perfect example. And given that the dean is a big vaccinologist, are you planning on exploring more vaccines for important cancers, particularly in Africa? Is that going to
Definitely.
be a focus?
I mean, we need to find the pathway, you know, where to intervene. But I mean, again, it's a seminar that I hope Patrick Robert and his group will be doing as an example, because his work is cutting edge to find superior, I don't know if that's the right word, but sort of the next generation of vaccine approaches to prevent hepatitis B. And that's an obvious area. Again, when it comes to like implementation science, you know, we're not preventing enough liver cancer with the knowledge we have now, but having a more effective and functional vaccine could help. But yeah, my hope is, you know, as an example, let's say that this connection with Fusobacterium and colorectal cancer turns out to be a real thing. I mean, I heard two things when I was in Boston. One group thought that it might be a facilitator. Another group said that the Fusobacterium colonized tumor and that increases the likelihood of metastasis. Either way, there should be an approach there. Maybe it's a vaccine approach, or maybe it's some sort of therapeutic approach. And then, of course, you know, if HPV is, you know, causing these additional cancers, we might not need a new vaccine there, but we need to make sure people are using that vaccine. You know, there is now a strategy. A lot of it is the data is led by Wits, Wits RHI with Sinead and others, to use a single dose of HPV vaccine to prevent that. But one thing that bothers me about that is it's only given to girls in Africa. And not only is epidemiologically that's sort of flawed, but also there are a lot of cancers that recur in men that are known due to HPV, certainly head and neck cancer, penile anal cancer. And we think that there might be a relationship, perhaps, we'll see, with prostate cancer. If that's the case, then that changes the whole game for HPV. But a lot of the real answer to your question is it really depends on what the studies end up pointing us towards. You know, if there's a target, then we definitely would push for development of a vaccine against that target.
Also like to acknowledge Prof. Mandeep Kaur, who's here from the Faculty of Science. Good to see some cross-faculty interactions. Any other questions there at the back?
Thank you. Yeah, nice presentation, and it's good to see how all this is coming together and the linkages. I just want to have your thoughts on, you mentioned about Global Health Institute at some point briefly, and then there was no traction, but I don't know what are the thoughts at the moment in terms of looking at the Global Health Institute?
I don't know, that's more of a Lynn question. I think that there's interest, there is a chair at Wits for global health, which is Helen Rees. Planned, okay, yeah. And so I don't know how that is going to develop and in what shape. I do think, I still feel that there should be one here. In fact, if I can move the one from Emory here, it just makes to me no sense. I mean, I just grew up in the United States, and I push for things there, but it makes no sense to have a global health institute there and not here, not in Africa, or in multiple places in Africa. So I do hope that that's something that happens. Maybe it needs to happen within the School of Public Health or driven by. I don't know if you have thoughts about it. Just to turn it back to you, Tobias. Was that Steve's hand going up?
Well, that was going to be the point. Rob, I think you're completely right to turn it back to Professor Chill and to Tobias. I'm sure it wouldn't be all of global health, but the School of Public Health, and there are quite a number of folk in the room here, I think would give it a lot of support. It's interesting how some of these terms are contested, and I thought you had a beautiful graphic of public health, global health, and the like. A question, if I may, Rob, just a broad question to reflect, and I share, as others have said, the pleasure of listening. In some ways, the IDORI is a proxy almost for intersections between that whole range of non-communicable conditions and infectious disease. And Glenda's successor at the Medical Research Council, Ntobeko Ntuzi from Cape Town, is at a very early stage of a Medical Research Council unit looking at that intersection around heart disease. But I wonder if you would just reflect a little bit more on those intersections, as much or as little as you're inclined.
Yeah.
Thank you.
Yeah, and it's also great to see you, Steve. And I have to say, I'm glad you enjoyed listening to me. When my daughter got married a few weeks ago, I was asked to give a toast, and my wife and I sang the toast. And so I considered singing today, but I think that might have had a negative effect. Yeah, I mean, I do think that focusing on cancer alone is kind of an artificial division, so that there are also a lot of known links and probably not fully understood links between diabetes, for instance, and infections. Certainly, as you point out with heart disease, we know about some factors that increase risk of atherosclerotic cardiovascular disease. And yeah, I think that's a wide open field. Actually, I was also at the Cleveland Clinic a few weeks ago, and the conversations with them were more around that. They were less interested in the relationship with cancer and more on issues of cardiovascular disease, on neurologic, on cognitive disorders, as well as diabetes. Yeah. So do press Tobias into that, and we can sit together to discuss that issue.
Yes, thank you. Thank you very much. I was struck by the way in which, at the end of a number of the graphs that you showed, and then in the context of talking around diseases, you continually highlight, correctly, that the prevalence of disease tracks inequality and problems around access. But what I didn't hear you talk about was how that is going to be represented as a question within IDORI.
You mean how we prioritize that as a research issue? Or?
Well, it seems to me that you can have the best possible assays and vaccines and tests of all kinds in the world, but if you do not have equitable access, it will fall over.
Yeah, exactly. And so, I'm fond of focusing on kind of the science approach to this, but I did have, one slide that enlisted first the implementation science issue. So, the poster boy for access to me is how can we have a cancer vaccine, HPV vaccine, that's underutilized? And how can we have new screening tools for early detection of life-saving early detection of cervical cancer that's not being implemented properly. It's not being taken up by the people who are at greatest risk. So I think that there's going to be an implementation science component to that. I don't know if that's addressing your question, but I think that there is a lot that needs to be done to improve access and to have hypotheses, implement something, test that, and evolve that. Did you want to follow?
No, I think just to comment on what she said, I think in terms of, I was thinking exactly the same in terms of looking at the implementation science. And I think we should reach out to WHO TDR. I think they have lots of frameworks looking at implementation science, and I think we are part of that particular group. Happy to have colleagues from the school to chat about that, because I think implementation science nowadays is really key to most of the trials that are happening, and trying to find bottlenecks and things like that.
Yeah, I mean, a lot of it's coming back to your comment and the question. As always, a lot of what you do is driven by the funds you could raise. And have you found, Tobias, the streams of funding to support the implementation science? But that's what we have to push for.
Yeah.
Go ahead. I think there was a follow-up.
I mean, there are lots of implementation science studies being done, and that includes in South Africa with the iHeart study, which is part of a Africa-wide study on HIV and heart intersections. And I think one of the challenges in that is around the relationship between the research arms and the testing of translation of research and communities who are supposed to follow it through. And I think that when I said access, I was much more thinking around the paucity of health services, and you highlighted that when you put up figures around numbers of oncologists and so on, but also the unaffordability of care. And it seems to me that there are major problems, not only on this continent, but globally, including in the US, where people's health status is a direct indicator of their economic status and their social inclusion or marginalisation, and I think that is relevant.
Yeah, I think that a lot more needs to be done there. I meant to thank you all, but also especially Kaz McNamara and Rifloi Machigo, who formed the core secretariat of IDORI and put a lot of effort into creating this seminar series. So thank you very much. And then Lynn, I think you were supposed to perhaps mention the next seminar that's coming.
Right. Yes. Well, I think this is a good time to wrap up and to first of all thank you, Rob, for really dedicating your time, your wisdom, expertise to us and to help us. And I know that you are only the interim director, but I know that you're going to stay connected to IDORI for a long time, even if you're not physically here. So thank you very much. But I think also it is important to acknowledge at this stage that that IDORI has been Prof. Shabir Mahdi's vision for a long time, and also I know Prof. Maria Papas is here too. I know she's put a lot of effort into building up IDORI, and many people here, because I definitely think it's poised to become a leading institute, not only in Africa but in the world. I think you've got all the right ingredients, the right leadership, the right levels of expertise, and obviously having a home, I think, is going to also make a huge difference. So this is the first, and the second is Professor Neil Martinson will be giving the next talk. So he's over there, and that will be on TB. And I think the other thing is that there's drinks and snacks associated with this, and I think they're going to be served right outside. So we invite all of you to come and enjoy that and chat and think about the next steps and make this regular in your diaries and your calendars. And I think the other thing we should really try and do is get the students here. Try and really encourage some of our students to come and attend these seminars because I think they're very useful. But also just I don't know if you know, Rob, that Wits gives you the edge was our former slogan. Did you know that? Okay. So the edgy team, yes, Wits gives you the edge. I think that might stick. So good one. All right, thanks everyone.